Welcome to the deep dive. This is where we take source material. Could be articles, research, or like today, some really focused revision notes, and we just, well, we boil it down for you.
Yeah, we cut straight to the essential knowledge, the core insights. Basically, the stuff you really need to grasp quickly.
Exactly. Think of it as your high-yield shortcut. Perfect if you're revising maybe for something like the MSRA or just want to properly understand a topic without wading through everything.
Right. And today, we're tackling Ebstein's anomaly, using these specific revision notes you, the listener, shared.
So our mission is clear. Unpack these notes section by section, pull out the core concepts, the key facts, those important nuances about this condition, make it high yield for you.
Okay, let's dive right in then. Definition first. The notes kick off by saying it was described quite a while ago, actually. Wilhelm Ebstein, 1866.
1866, okay. So it's been known about for a long time. But what is it, fundamentally?
Well, the notes define it as a malformation. It involves two main things, the tricuspid valve and the right ventricle.
Right, the valve between the top and bottom chambers on the right side of the heart and the main pumping chamber on that side.
Exactly. And the absolute key feature, the thing that really defines Ebstein's, is the position of that tricuspid valve.
Okay.
Instead of sitting where it should at the junction, the functional annulus, where the valve leaflets actually attach and work, is pushed downwards. Apically displaced is the term, deeper into the right ventricle.
So the working part of the valve isn't in the right place. It's lower down than normal. That sounds significant.
Oh, it's crucial. And there are other features that go along with this. The notes mention that parts of the valve leaflets themselves, the septal and posterior ones specifically, aren't free. They're actually kind of stuck or adherent to the heart muscle.
Stuck leaflets in a valve that's too low? Okay. I can see how that would cause problems with blood flow.
Definitely. And the notes also describe what happens to the right ventricle because of this. The part of the ventricle that's now above the displaced valve but below the normal junction. It gets dilated, the wall changes, might thin out or thicken.
And that's the bit they call atrialized, right?
Yes, exactly. The atrialized right ventricle. That's a really key term. It means this section, this chunk of the right ventricle, isn't really acting like a ventricle anymore.
Functionally.
Functionally, yeah. Because the valve's sitting below it, it effectively becomes part of the right atrial chamber, structurally and functionally. It's not contributing properly to pumping blood forward. It's atrialized.
Got it. So the pumping part of the right ventricle is smaller than it should be. And the notes also mention issues with the other leaflet, the anterior one.
Yeah, it can be big and floppy redundant or have holes, fenestrations, or it can be tethered, sort of restricted in how it moves. Plus, the whole junction between the right atrium and ventricle tends to be dilated.
Wow. Okay. So it's a whole constellation of issues. Displacement, stuck leaflets, abnormal leaflets, and this atrialized chamber. That's Ebstein's anomaly.
That's the anatomical picture, yes.
Okay, let's switch gears. Where does it come from? Etiology? The notes are clear. It's congenital. You're born with it.
Correct. And it's described as multifactorial, which basically means it's usually not just one single cause.
Right, more like a mix of things.
Probably, yeah. A combination of maybe some genetic predisposition gene mutations, perhaps chromosomal issues, and environmental factors interacting.
And this all happens during development in the womb.
Yes, during fetal heart development. That's when the structures don't form quite correctly. The notes also list some really key associations, things you often see alongside Ebstein's.
Okay, like what?
Well, tricuspid regurgitation is almost universal. Makes sense, right? Faulty valve leaks.
Yeah, that follows. The notes mention a pansystolic murmur for that.
Yep, that specific whooshing sound heard all through the heart contraction phase as blood leaks back into the right atrium. And then there are electrical issues. Wolff-Parkinson-White syndrome, WPW.
Ah, the accessory pathway condition.
That's the one. Found in about 15% of patients with Ebstein's, according to these notes. That's quite a strong link.
15% is definitely something to remember for exams.
Absolutely. And another common electrical finding is right bundle branch block on the ECG. These associations are important because they affect symptoms and management.
Okay, moving from causes to risk factors. The notes stress that most cases just happen, sporadic, without a clear family link.
Yeah, familial cases are rare, but even though most are sporadic, the notes do point back to those potential genetic and environmental factors influencing risk.
And they mention some specific environmental ones again.
They do. Maternal exposure to benzodiazepines during pregnancy is listed, and less commonly maternal lithium therapy.
Interesting, they flag those specifically.
It is. Also mentioned is a slightly increased occurrence in twins, and if there's a family history of other types of congenital heart disease, not necessarily Ebstein's itself.
But the main takeaway is still that it's usually sporadic.
Right. It highlights that we don't fully know all the triggers for this specific malformation during development.
Okay, let's connect the anatomy to the problems it causes. Pathophysiology. How does it actually work? Or rather, not work?
So the notes lay out a sequence. Starts with that malformed, low-set tricuspid valve.
Which leads to that atrialization of part of the ventricle we talked about.
Exactly. Functionally incorporating it into the right atrium. And because the valve is leaky, that tricuspid regurgitation blood flows backwards into the right atrium during systole.
So the right atrium has to cope with its normal incoming blood plus this leak back.
Precisely. So it enlarges, often quite significantly, to handle that extra volume.
Okay, and the regurgitation means less blood is going forward effectively.
Yes. And because part of the right ventricle is functionally lost to the atrium and it's dealing with the volume overload from the leak, the remaining functional part of the right ventricle gets strained. It becomes overloaded and over time can start to fail right ventricular dysfunction.
That makes sense. It's a chain reaction.
Yeah.
Bad structure leads to bad function, chamber enlargement, overload, and eventually pump failure.
That's the core pathophysiology. And the notes make a really critical point here. The severity varies massively.
Right, from no symptoms at all
To really severe, life-threatening problems. It all depends on how displaced the valve is, how much ventricle is atrialized, and how bad the leak is.
Which explains why some people aren't diagnosed until adulthood.
Absolutely.
Okay, so when someone presents with symptoms that could be Ebstein's, what else does a doctor need to consider? The differential diagnosis list.
Yeah, what else could it be? The notes give a list, things causing fast heart rates like accessory pathway, tachycardias, SVT, WPW obviously need ruling out given the association.
Makes sense. What else is on the list?
Other congenital heart diseases that cause cyanosis, other problems specifically with the tricuspid valve like dysplasia or prolapse, conditions affecting the right ventricular muscle itself like arrhythmogenic right ventricular cardiomyopathy, ARVC.
Okay. Things like atrial septal defects are mentioned too.
Yes, ASDs. Also, just severe right heart failure from any other cause needs distinguishing, and transposition of the great vessels.
So quite a few possibilities that can present similarly with cyanosis or right heart issues. Careful workup needed. What about epidemiology? How common is this? The notes say it's rare.
Very rare, yes. In the UK, it's apparently less than 1% of all congenital heart disease cases.
Less than 1%. That's
Right.
not many.
No. Although the notes add a caveat, the true prevalence might be a bit higher because very mild forms could potentially go undiagnosed throughout life.
Right, the asymptomatic end of that spectrum we talked about.
Exactly.
So clinical presentation. How do patients actually show up?
Yeah.
The notes reiterate the underlying issue. The congenital malformation, the valve, the ventricle, the atrialization.
And again, that huge variability in when it presents could be picked up on a fetal scan or present in infancy, childhood, or, way later in adulthood.
Depends on severity.
Yeah.
And the symptoms listed, cyanosis is a big one.
Yes, that bluish tinge from low oxygen. Fatigue, getting breathless easily, especially with exertional dyspnoea.
Palpitations too, presumably from the arrhythmias.
Very common, yeah. Linked often to that WPW. And then symptoms of heart failure can develop swelling, difficulty breathing when lying flat, and so on.
The notes also mention other associated anomalies can sometimes be there, like with other valves or the lungs.
Yes. Things like bicuspid aortic valves, pulmonary stenosis or atresia, mitral valve issues can sometimes coexist.
Okay. And what might a doctor find on examination?
Well, again, depends on severity. You might see the cyanosis or clubbing of the fingers and toes if cyanosis has been long-standing. Sometimes the chest might look a bit asymmetrical, precordial asymmetry.
What about the neck veins, jugular venous pressure?
Could be normal, or it could be raised if there's significant right heart failure. And if heart failure is present, you might see peripheral edema, swollen legs, and enlarged liver, hepatomegaly, maybe ascites, fluid in the belly.
And the heart sounds, we mentioned the murmur.
Yeah, abnormal heart sounds are common. That pansystolic murmur of tricuspid regurgitation is often a key finding. You might hear other sounds too, like widely split second heart sounds or extra sounds like S3 or S4 gallops.
Lots of potential clues there. So how do we confirm it? Let's run through the investigations. Chest x-ray first.
CXR can be normal, especially if it's mild, but often, particularly in more severe cases, you see cardiomegaly, a big heart. And the notes mention that classic description, a box shape or globular heart, because the right atrium can get massive.
Box shape. That's a good visual for revision. Increased lung markings sometimes, too.
Yeah, if the forward flow to the lungs is reduced. Okay, next, ECG.
Electrical activity.
Typically abnormal. You're looking for signs of right atrial enlargement, tall, broad P waves, sometimes called Himalayan P waves. Right bundle branch block is very common. You might see small R waves in the early chest leads, V1, V2. Some other specific QRS pattern changes too.
But the definitive test, the notes emphasize, is the echocardiogram.
Absolutely. Echo is king here. Ultrasound of the heart. It lets you see the tricuspid valve. You can measure how far down it's displaced, see how the leaflets are moving or if they're adherent. You can assess the size of that atrialized ventricle segment, and importantly, grade how severe the regurgitation is.
So echo confirms the diagnosis and tells you how bad it is.
Pretty much, yeah. It's essential. Cardiac catheterization is mentioned.
But rarely needed just for diagnosis.
That's right. It's more invasive. Might be used sometimes to measure pressures or assess other things, but not usually the first step for diagnosing Ebstein's itself. However, electrophysiology studies, EP studies, are mentioned.
For the WPW and other arrhythmias.
Exactly. If there are significant arrhythmias, EP studies help map out those extra electrical pathways. The notes say they're often right-sided pathways, and interestingly, about half the patients studied have more than one pathway. This helps plan treatment, like ablation.
Okay, diagnosis confirmed, severity assessed, management. The notes split this into medical and surgical.
Yep. Medical side is about managing the consequences and preventing problems. So antibiotics before certain procedures to prevent infective endocarditis, that valve infection risk.
Because the abnormal valve is more vulnerable.
Right. And then managing any heart failure symptoms with medications and treating the arrhythmias, again, often with drugs or sometimes ablation based on those EP study findings.
Okay. And the surgical approach. Timing seems important.
Yeah, the notes mention considering early surgery if there's significant heart failure. Neonates might need surgery, but also patients presenting later, even over 50.
And the type of surgery.
The preference is usually for tricuspid valve repair, if possible, rather than replacing it. Trying to use the patient's own tissues. If replacement is needed, they often use bioprosthetic or tissue valves.
And it's often more than just the valve itself.
Often, yes. Surgery might also involve resecting some of that dilated atrialized ventricle and right atrium, closing any associated holes like ASDs or PFOs, and sometimes surgically addressing the arrhythmias at the same time.
Complex procedures. What about very severe cases?
For really sick infants, sometimes palliative shunt procedures are done first, as a bridge. And for select patients with end-stage failure, heart transplantation is an option.
A whole spectrum of interventions. Okay, prognosis. What's the long-term outlook? Notes say variable.
Highly variable. It really depends on those factors we keep mentioning. How severe the anatomical defect is, how bad the leak is, presence of heart failure, other defects, arrhythmias.
Milder forms diagnosed in adulthood generally do better.
Generally, yes. But for the more severe end, without surgery, the outlook isn't great. The notes quote a statistic. Less than 5% survive beyond age 50.
Wow. That really highlights the impact in severe cases and why management is so crucial. What about being diagnosed very early?
Fetal or neonatal diagnosis of severe Ebstein's can have a poor prognosis. But the notes do say modern surgical approaches have significantly improved outcomes for neonates compared to decades ago.
That's positive news. Pregnancy, as mentioned, is generally well tolerated.
Yes, which is important information for female patients. And it just underscores the spectrum. Again, there are rare reports of people living into their 70s or even 80s with Ebstein's.
Depends so much on the individual case. Lastly, complications. What are the main risks?
Well, right heart failure is a major one, stemming directly from the pathophysiology. That risk of infective endocarditis we mentioned for prophylaxis.
And then issues related to potential shunts.
Yes, paradoxical embolism. If there's a hole between the atria, like a PFO or ASD, a clot from the veins can bypass the lungs, cross over to the left side, and go to the brain, causing a stroke or TIA.
Nasty. Brain abscess is listed too.
Same mechanism, basically. If there's bacteria in the venous blood, it could potentially cross over and cause an abscess in the brain via that right to left shunt.
And the final one listed is sudden cardiac death.
Yeah, often linked to those severe arrhythmias, particularly associated with WPW. It's a known risk that needs careful assessment and management of the electrical side of things.
Okay, phew. We have definitely dived deep into those notes, covered a lot of ground there.
We really have, from the basic definition, the anatomy, the why it causes problems, right through to diagnosis, management, and what the future might hold for patients.
hopefully breaking it down like this, pulling out those key terms like atrialisation, apical displacement, the associations like WPW, and the main investigation findings. Hopefully that makes it stick for your revision.
Yeah, making it high yield. And maybe a final thought for you to consider, building on all this. Given that huge variability and the improvements we're seeing, especially in early surgery,
Yeah.
how might future developments, perhaps in fetal diagnosis and even potential fetal interventions, or maybe even gene-based therapies down the line, how might they further change the outlook for babies diagnosed with Ebstein's anomaly even before birth?
That's a really interesting point. The field is always moving. A lot to think about. Well, thank you for joining us on this deep dive into Ebstein's anomaly.
My pleasure. Always good to break these topics down.
And for you listening, if you want more resources, especially if you're revising for the MSRA, do check out pastthemsra.com.
And there's also freemsra.com for, well, free resources.
Until next time, keep exploring.
Keep diving deep.